educational series, and today we have Samantha Dallefeld, okay, who is the co-chief fellow here at the DCRI this year. She's going to be talking to us about shock and sepsis in pediatrics, and I'll let her tell a little bit about herself.
Hello? It is? Okay, perfect. Okay, great. Hi, everyone. As Karen mentioned, I'm Samantha Dallefeld, so I'm a third-year pediatric critical care fellow over at Duke, and then a second year here in this program, and as she mentioned, one of the chief fellows. So most of the research that I do is with the clinical pharmacology peds group, looking at drug trials and clinical pharmacology of drugs. And specifically, my interest is obviously the critical care population and also ECMO, which I'll have one slide about it at the end of this presentation. So this can be pretty informal. So if you have questions as I'm going, feel free to ask. But there also should be time at the end for questions if there are any. With that, and the title of my presentation, I guess, gives this away a little bit, but anybody have an idea of what all of these people have in common? They all had sepsis at some point, and actually many of them died from sepsis. So there's actually, most of them you'll probably recognize. Karen asked me prior to, who's this little guy? And he's actually President Coolidge's son, who died at, I want to say he was 16 from sepsis. So this is definitely a pediatric disease as well as an adult one, and is really sort of bread and butter in terms of the world of pediatric critical care and sort of what we take care of on a daily basis. So I'll talk a little bit about sepsis, but also shock. And this actually September is Sepsis Awareness Month, turns out. So I thought that was a nice connection to talk about this today. And so this video is from the Sepsis Alliance, and I thought that I would play it just as a little bit of an intro to sepsis.
A 20-year breast cancer survivor. She dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I said, I don't know.
Really, does it affect that many people? Then why haven't I heard of it?
My mother, Mama, she had plans of being a gospel singer. They found a clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath. When I heard the word sepsis, I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another. All of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up crying. I took his temperature, 102.3, and his color was great. His lips, everything was great, and he was not responding. We got to the hospital. He got swelled up, so he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I've been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection. And then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending. And it's why I share my survivor story.
And the nurse, her name is Annie, and she says, "Are you ready to hold him?" And I said, "Oh my God, yes." She put him in my arms. And she says, "He's gonna be okay." I thought maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
Okay. Sorry, that started out as a little bit of a tearjerker, but a lot of people don't know much about sepsis and what sepsis is, and they said a lot of different things in there: sepsis, septic shock, and we'll talk about the differences in those things and what those are, and then we'll talk a little bit about both the epidemiology of it. In fact, epidemiology of it. We'll talk about the terminology, as I mentioned, discuss early recognition and some of the management of it. So in true doctor fashion, I like to start always with a case presentation. For me specifically, it's great when I can learn about something, but when I actually have a patient that I can sort of connect it to, it helps to put it, helps me to remember it a little bit better and to understand it a little bit better. So over at the hospital, if I have a patient, so if there's a patient admitted to the regular floor outside of the ICU, and somebody is worried about them for whatever reason, it could be the doctors, it could be the nurse, it could even be the parent, they can call a rapid response. And the ICU team will come check on them and evaluate them and potentially bring them over to the ICU if it's necessary. So this is a case of a 6-year-old boy who they called a rapid response from 5100. We get over there, the nurse says this little boy had chemotherapy a couple weeks ago for leukemia. He's had fever now for a couple days, and I'm concerned that he looks septic. Talked about the objectives. So before we start, let's talk about a few definitions. These will be really important as we're going along in this presentation. So bacteremia or viremia is the presence of bacteria or virus in the blood as determined by a culture. There are, as the video mentioned, any infection can lead to sepsis, a respiratory infection, a urinary tract infection, but this is one of the most common ones that we see. SIRS stands for Systemic Inflammatory Response System, and to qualify as having SIRS, and usually we say somebody looks SIRSy, you have to have 2 of these things. So a temperature that's either too high or too low, a heart rate that's above the 90th percentile for age, the same for respiratory rate, and then a white blood cell count, which is too high or too low for age. And also as I'm going along in this, I know that a lot of you guys work with medical stuff. I'll do my best not to use a bunch of medical jargon, but if I do say something that you're like, what is that? Just let me know and I'll stop. So the white blood cells, in terms of the cells that respond to infection and inflammation in the body, either being too high or too low. So sepsis is when you have SIRS, 2 of those criteria, and then you also have infection, documented infection, or clinical evidence of infection. And then one step up is severe sepsis, where you have sepsis, and then you also have signs of poor organ perfusion. And we'll talk a little bit about what that looks like as we go through the case in the presentation. And then septic shock is when you have severe sepsis. You also have low blood pressure, and it's not responsive to fluid. It's usually the first thing we do when somebody's blood pressure is low is we give them fluid, and we usually give them a big bolus of fluid, 20 mLs per kilogram of body weight. And if they still have low blood pressure despite that and require some pharmacologic agents to support their blood pressure, then that qualifies them for septic shock. So going back to Matthew, so these are his vital signs. His heart rate's 168, his blood pressure is 86/43, his respiratory rate is 40, and he is febrile. He has a temperature of 38.7. He has mild retractions, and so when he's breathing, you can kind of see that he's sort of pulling in here. He's like pulling in under his ribs, and so you can really see that he's using a bunch of extra muscles to breathe. He has poor capillary refill, so when you sort of pinch his fingers, it takes a long time for the color to come back to his hands. He's very cool in his legs and his arms. And then he's pretty lethargic, and he sort of responds when you talk to him, but it's pretty sluggish. So if any first impressions? Sounds like he probably doesn't look pretty good if you're standing there at his bedside, and this is definitely a patient that I would pretty quickly tell the nurse, he's coming with me to the ICU. So we ask, can you please start an IV on this patient? Let's draw some basic labs so I can sort of see where some things are starting, and let's get those fluids on board. And we'll talk a little bit more about that in this patient. A few pearls for pediatrics. So blood pressure. So we know in all of us, the sort of 120/80 is a normal blood pressure, and that's sort of what you're looking for when they're taking your blood pressure at the doctor's office and hoping that it's normal. So in kids, it's different, and these are some of the guidelines that we use for kids. So in newborns, we want their top number, their systolic blood pressure, to be greater than 60. And then for ages 1 through 10, we use this formula, 70 plus 2 times the age. So Matthew is 6, so 70 plus 2 times 6. So 82 would be sort of his low end of normal for his blood pressure. His blood pressure was 86 over something, so actually his blood pressure is hanging in there. But that's sort of a good one to remember. And then usually for the higher end of normal, I use 90 plus 2 times the age in years. And so that gives me sort of a guideline of where I think that they should be. Elevated heart rate is really important in kids, and it actually can be one of the first signs of sepsis or shock. It's very nonspecific. Kids' heart rates go up for every reason. They're mad. It can go up just because they have a fever, they're breathing hard. You give them a medicine, that makes it go up. But it's very important to recognize in shock because it can really be your first sign. So it looks like Matthew has severe sepsis. We mentioned his heart rate's up almost 170, which is way too high for a 6-year-old. His blood pressure is normal. He's normotensive, sort of getting there, but it's hanging in there for now. But he's also febrile, so his heart rate being high and his temperature being up means he has the SIRS criteria. And we have suspected infection, which may not have been totally clear from the data that I provided, but we know that he had chemotherapy a couple weeks ago. And so if we know anything about chemotherapy, that's going to wipe out your immune system and make you more susceptible to infection. So that is really high on the list of suspicion for this child. So meets SIRS criteria, has a suspected infection, and then does have some signs that he's not getting great organ perfusion. Specifically, they described him as lethargic. And usually when a child is lethargic, and sometimes it's just because they don't feel good, but sometimes it's because they're just not getting enough oxygen to the different places in their body, specifically their brain, in order to make them perky and nice and alert. So this patient has severe sepsis. And so whenever that is the case, sort of the clock has started in terms of our management. And as you'll see, time to treatment of these patients, and as you probably saw in the video at the beginning, is very, very important. And so that's why early recognition is really important, and also early intervention is really important. So let's talk a little bit about epidemiology of sepsis. So this is from an article back in 2003 that looked at epidemiology of pediatric sepsis, and they looked at they had a database that used patients from over seven states. Excuse me. So they looked at about 10,000 cases of severe sepsis. The results included 0.56 cases, so about half a case per 1,000 children, and then they estimated just over 42,000 cases, and this is again just in pediatrics, per year in the US. So as you can see from this graph, with incidence per 1,000 children being on the Y and then age groups being on the x-axis, it's definitely more prevalent in the younger age groups. That's really because their immune systems just aren't as robust. Their barriers to infection just aren't as robust, and so they're much more susceptible. And then it sort of decreased after the first year of life. This article also looked at the primary etiology. So most of the time we're seeing sepsis related to a respiratory problem, like they get a bad pneumonia and they get septic from that, or they get a bad virus and get septic from that. And sometimes that's more difficult for us to treat than a bacteria because I don't have good antivirals to get rid of things. So if you have a staph infection, I have an antibiotic for that, but a virus I really don't. And so oftentimes we're just supporting their body as their body fights it off. And then primary bacteremia. So the initial infection is that bloodstream bacterial infection. And then a host of other things, UTIs, abdominal things, an infected skin rash can cause it, like a MRSA infection, meningitis, endocarditis, device-related infections, like you have a pacemaker or you have lines or something like that that gets infected. But most of them falling into the top two categories, respiratory and primary bacteremia. So mortality is about 10%, so not negligible in this population. And again, this is children. I don't know the adult data as well. But 5.8 deaths per 100,000 children in the US, and about 50% if you have an underlying comorbidity. And so that is something our patient qualifies for, right? They have cancer, they're on the chemotherapy. That's going to put them at higher risk for mortality than if it was an otherwise healthy 6-year-old child. And again, mortality by age group, it's going to be more so. It's going to be more likely to be fatal in the less than 1-year-old group than the older kids. So these are some of the high-risk populations. So anytime you have a baby that's born low birth weight or very low birth weight, they are at higher risk. In fact, 2/3 of neonates with severe sepsis are low birth weight or very low birth weight. Chronic lung disease, so if you have a patient that is maybe has a tracheostomy for some lung problems they have and they live at home on a ventilator or something like that, they're much more at risk. Congenital heart disease, neuromuscular disorders, as mentioned here. In fact, 1/4 of 1 to 9-year-olds with severe sepsis have underlying neuromuscular disease. Like Duchenne's muscular dystrophy, for example, could fall into that category. And then cancers, neoplastic disorders, and 1/4 of 10 to 14-year-olds with severe sepsis have an underlying neoplastic disorder. And they're a really high risk group, as I mentioned, because they're on chemotherapy and that's knocking out their immune system. And bone marrow transplant population is also another one that's very high risk. So a little more on Matthew. So I mentioned he had cancer. He was diagnosed with ALL, acute lymphoblastic leukemia, 3 months ago. Otherwise, he was healthy, but that is a pretty big hit to his little body. His vital signs are unchanged after we give him that big bolus of fluid. So we order more fluid and say, let's start antibiotics really early. And we'll see that that's really important. And again, transfer him to the PICU. So in terms of organisms, I won't go too much into detail with this, but these are some of the organisms that we most commonly see as causes of sepsis. Again, there can be viruses, there can be fungal infections that cause sepsis, but these are some of the most common bacteria. Fortunately, Haemophilus influenza and Streptococcus species, at least some of them, are much, much decreased because we have vaccines against them. Thankfully, because they can be pretty terrible illnesses to have. However, some of that has made other ones increase. So Haemophilus influenza is down, which means Neisseria meningitis is up. But these are sort of the most common ones we see. E. coli, the third one down from the top, is the most common cause of a urinary tract infection. And so if there is a urinary tract infection that then causes sepsis, it's usually from E. coli. And that's pretty prevalent in the neonatal population. I'd say that's probably the most common infection that they get, but their barriers between their urine and their blood and their brain are just not as robust. And so you can get one infection, it can travel through their body pretty quickly. That's one reason if you know anyone who has had a baby in their first 30 days of life that's had a fever, they go to the ER and it seems like the book is sort of thrown at them. They get a blood culture, they get a urine culture, they get a spinal tap, and that's across the board no matter what. And it's because they're just so high risk for really bad problems and sepsis, and their mortality is so much higher that we are sort of a better safe than sorry approach, and that's really across the board for kids in that age group. I also won't go too much into antibiotic choice, but anytime we send a culture to the lab, it's the first thing that is going to come back is this looks like a gram-positive organism or this looks like a gram-negative organism. And we usually treat based on, well, first we're going to treat very broadly, and then we can sort of guide our management based on any initial things the lab gives us. It looks like this, and then we can sort of tailor management appropriately. We sort of have our own guidelines. If it's this age group, these are the bacteria that we're most worried about, and we're going to start these antibiotics. Or if it's this age group, or if it's a patient that's on chemotherapy, these are the bacteria that we're most worried about. But these are some of the most common ones that we use for treatment of sepsis in the pediatric population. So early antibiotics saves lives. This is one of the reasons at the beginning I said we like clock starts. We want to get them some fluids. We want to get them on antibiotics. So this study, you'll see odds ratio of death on the Y, and then time from the onset of low blood pressure on the x-axis. And even after the first hour, there's an increase odds of death in this population. So really getting antibiotics on board is hugely important, and the guidelines will say really within the first 30 minutes you need to have antibiotics started, and there has been data that shows that that decreases mortality. So back to Matthew. We gave him that second fluid bolus. His heart rate's 179, so no improvement there. In fact, maybe we've made it worse. His blood pressure is 67/38, so we're falling. Respiratory rate is 40. Temperature is 38.7. So really not a lot of change, and if nothing else, he's worsening. Not uncommon, even if you're doing everything right. This is an aggressive disease. Bacteria are aggressive, especially depending on what bacteria it is. And so often, despite doing everything right, you're going to worsen. And some of that is getting on top of it, and some of that is just the body's response. So he still has a delayed capillary refill, so maybe even more so than before. When you sort of look at how long it takes the color to come back to his hands and his feet, it's taking 4 seconds or longer, and still very cold. And now, when you try to mess with him or pinch him or whatever to get him to respond to you, he's pretty minimally responsive to pain. So now he's in shock. So that is not where you want to be, but unfortunately, oftentimes where we end up. Sometimes we can stave that off if the recognition is early enough. For example, the rapid response in this patient said he'd been febrile for 2 days. Could we have done something 2 days ago to get him started on antibiotics, and he may have been a little sursy, but not advanced to shock? I don't know, and usually we don't know, but now he's in shock, which is not an awesome place to be. So we'll talk a little bit about shock, and there's several different ways that we sort of define it. We can define it both by the etiology or what's causing it, with sepsis being on there, but you can be in shock from loss of, from being very dehydrated, hypovolemic, or from lots of blood loss, which I think is up there, hemorrhagic. If you're in a bad car accident and you just have lots of blood loss, that can have send your body into this shock state. So there's lots of different causes. We're specifically focusing in on the septic etiology, and then there's physiologic ways that we describe shock as well, and we'll talk about those a little bit more in the subsequent slides. Warm versus cold, and also different stages of shock. So if a patient is in cold shock, that sort of sounds like Matthew. So they're just really cold and clammy. What's going on the inside is their blood vessels are just all clamped down, and so their perfusion, their blood flow to all their extremities is just not robust. And so when you touch them, they're just sort of ice cold. They may be very mottled. And that is in stark contrast to warm shock, when their blood vessels are actually really dilated and big, and they're you've sort of lost integrity of the vessels, but you're just in this big, huge inflamed state, and they're febrile and they're warm and they're red, and both can be a result of septic shock, but we may treat them a little bit differently. Because on the inside there's a little bit of a different pathology going on just because of how their body responds to it. So shock in general, so we talked about septic shock, but the blanket term shock is really inadequate oxygen to meet the demands of the body. So your body needs oxygen and nutrients to do all of the things that it needs to do, and if you don't have enough oxygen to deliver to do all of those things, then that can send the body into a state of shock. So certainly when you have sepsis and a severe infection, that can cause this, but kind of going back to some of those other etiologies, if you have lots of lots of blood, or you're dehydrated from throwing up from a stomach bug or something like that, that can also send the body into shock. So different stages of shock, you can have compensated, you can have uncompensated, you can have irreversible shock. Compensated and uncompensated really refer to what the blood vessels are doing. Are they able to compensate and sort of maintain your blood pressure? And so your organ perfusion and function is pretty maintained, or is it uncompensated, where perfusion to all your little small vessels is not that great, your organ function and your cellular function begins to tank, your blood pressure tends to tank, and that sort of uncompensated shock. And then irreversible is when you just have sort of failure inside the body, your organs fail, and oftentimes that is irreversible. So something that I always like to talk about in kids with shock and septic shock is they're not little adults. They're actually quite different in terms of their body's ability to respond to things. So oftentimes, if you're running a marathon and your body is saying, I need more oxygen, then you have the ability to beat your heart harder and inject more blood every time your heart beats to get the appropriate amount of oxygen out to do the things that you need to do. So kids often cannot, their heart isn't as big, I mean it's a muscle, but theirs isn't as big and robust a muscle as yours and mine. So they often cannot eject a ton more blood with each squeeze. So their response to needing more blood out to their body is just for their heart to beat faster. So that's why increased heart rate is often one of the first signs that we see, because that is their compensatory mechanism to saying, I need more oxygen. My body needs more. It's taking more nutrients. It's taking more oxygen. I need to get more out. And so they beat harder so that they're sending more out that way. Or they're beating faster, sending more blood out that way rather than beating as hard and getting more blood out with each stroke. They can also elevate their systemic vascular resistance a lot higher than adults. So that's really that squeeze of the blood vessels. So adults just really don't have the capacity to do that as well, but kids can. So when their blood vessels get huge and dilated, that can make your blood pressure tank. But kids actually have the ability to squeeze down those vessels a lot easier. So oftentimes their blood pressure is maintained a lot longer than in adults. In fact, when we are in sepsis or septic shock, one of the first signs you may see is our blood pressure tanks. But oftentimes in kids, that's actually a late finding. And so if you see that, you may already be behind the 8 ball. So what do you do next? So in kids and in PICU and in critical illness, we talk about ABCs. So we want to make sure their airway is patent, they're breathing okay, and that their circulation is fine. And so that is sort of the first thing when a patient that maybe has lack of end organ perfusion, that has is lethargic, is maybe mentally responsive to pain. The first thing I want to know is, can they protect their airway? Are they breathing okay? Are they awake enough to do that? Because that you may want to intervene on that first. If they're not breathing, then you can't even get to antibiotics because they're not going to make it there. So that is where we start, again, intervening early and knowing that time is of the essence with these patients. There was a randomized control trial in adults back about 15 years ago now with severe sepsis and septic shock, and they really used this goal-directed therapy. They said if we can all do this the same and really look at all these things, these signs of end organ perfusion and oxygenation, and make sure that all of these things are optimal, will it help? Will it save lives? And so the goal was that their blood pressures, their mean arterial pressure, their MAP was at a certain level, their urine output was at a certain level, their oxygen saturation, as SaO2 greater than 93% was a certain level, their hematocrit, or how they weren't too anemic, that was right. They looked at all these different things, and a lot of times in adults that required a big, huge catheter in their body to monitor all of these things, and their study actually showed that it did decrease mortality from 46.5 to 30.5%, so about 15%, which is not negligible, with a significant p-value. And so for a while it was, okay, like this is the way that we need to do this. However, there were 3 subsequent multi-center trials that tried to confirm these findings, none of which showed benefit. And so while a lot of these guidelines are still sort of what we aim towards in terms of optimizing therapy, it's no longer as protocolized as that and requiring a big, huge catheter to monitor how much blood flow is coming back to the heart and all of those kinds of things, just because it hasn't showed the mortality benefit that we initially thought that it did. So in kids, again, a little bit different. In kids, whenever these studies came out, we were like, well, that's great, but I'm still not putting a big, huge honking line in this child to measure all these things, because that is high risk as well. So we really target normal blood pressure for their age. We're trying to target, let's be normal. So normal blood pressure, let's have good, let's be peeing, let's have an adequate number of red blood cells, let's have a good oxygen level in the 90% range. And then we can use some other markers as well. We can evaluate if we think we're getting enough out of the heart based on what does our perfusion look like? What is our capillary refill? Are we building a lactate? And we'll talk a little bit about that in a subsequent slide. There's this fancy new thing called a cerebral oximeter, or a NIRS, it's near infrared spectrometry, and a lot of us have seen the little pulse ox they put on our finger to check our oxygen saturation. That checks our oxygen saturation in our arteries, and now we have one that actually can monitor the oxygen saturation in our veins. So after the blood leaves the heart and goes throughout the body, what's sort of coming back, and that can give us an idea of how much are we left with? Is the body getting enough? Does it have some to spare as it's coming back, or not? Are we getting pretty low and we need to try to give the body more oxygen because it doesn't have, we're kind of running on reserve. So these are the septic shock guidelines for kids. So again, recognizing shock. And then the PALS guidelines is the Pediatric Advanced Life Support Guidelines. And they talk about maintaining the airway, remembering that ABCs come first, establishing good IV access so that we can give the blood products, or give the fluids and potentially blood products and other medications that we need. Within the first 5 minutes, they want you to get in 20 milliliters per kilogram of body weight, which if a child is, 30 kilos, you can imagine how much fluid you're trying to push into this child. That's what, 500, read that math quickly off the top of my head, 600, 1,800 mLs of fluid. So almost a couple liters of fluid you're trying to get into this child as quickly as possible. And actually that was some of the contradictions to the goal-directed therapy study, is that are we giving too much fluid? Are we just popping these adults and kids full of all this fluid, which, yeah, is great in the initial because you're making their blood pressure look better, but then what are you left with on the other side? And if you remember back to the initial video where she said her baby puffed up and just was huge and swollen, and that is actually what we see, because the blood vessel integrity is, as I mentioned, just not that great because the body is inflamed, and so a lot of that fluid you're putting in there is just leaking out into the body and into the tissues rather than staying there in the vessels. And so, but you have to have a blood pressure to be alive. So we support that. We give them 3 20 per kilo boluses of fluid before we say, okay, that's enough. Let's support their blood pressure some other way. Again, we want them to be normal. So you want to correct if their blood sugar is low or if their calcium is low. Your body needs sugar for energy. Your heart needs calcium to function appropriately. So we're trying to optimize everything and get things normal. And then again, they want you to start antibiotics within 5 minutes. which oftentimes you can't even get antibiotics ordered in 5 minutes, much less get them ordered, get the pharmacy to make them, and then get them to the patient and in the patient in 5 minutes. But that's sort of the goal, is as early as possible, you need to get those ordered and have them there. And then again, you want to get the patient to the PICU where they can be monitored more closely, determine if the child is in shock, so refractory to that fluid, in which case you may think of starting some vasoactive agents to help augment your blood pressure. And then at 60 minutes, you're sort of evaluating it. Okay, if this isn't working, what else can we do? So this is another study back from 2003. It was a retrospective review of 91 resuscitated infants and children that actually showed, following those guidelines, so both the PALS guidelines, but also those sort of early interventions, the fluids early, the antibiotics early, did that increase the odds of survival? And their results stated that mortality doubled for every hour of untreated shock, and did show a pretty significant increase, about almost 30% survival when the PALS ACCM guidelines were followed. And so that in pediatrics is sort of our goal is, can we normalize this patient? Can we try to get the blood pressure normal? Can we try to make sure they're peeing? If they wake up and look at me and say some stuff, I am really happy, because that means they're maintaining appropriately, which shows me that maybe their end-organ perfusion or their perfusion to their brain is improving. So treating shock, again, shock, inadequate oxygen delivery to meet the body's demand. So it's all about oxygen delivery and oxygen consumption, and really treating those underlying causes. So this will look a little bit scary once I put all the other stuff on it, but this is sort of everything that I'm trying to do. So normally, oxygen delivery, how much you're pumping out of your body, is way in excess of how much you need. So your body can only consume so much, it only needs so much, and so oftentimes we're sitting like, I don't know if this works, we're sitting like way over here on this end. Tons of delivery, we don't even need it all. A lot of it's coming back. I mean, you may be pumping out, your blood is 100% saturated with oxygen when it leaves, and when it's coming back, it's like 75. So lots of extra. But as a child gets sick, they sort of start to move this way down the curve. So this is supply is independent of demand. Your delivery is way in excess of consumption. And then once you get to the critical oxygen delivery point, that's when things sort of tank, and your body starts saying, okay, I don't have enough oxygen, so I better find another thing to use for energy, because I need to do all of my normal functions, but I don't have enough oxygen to make the energy to do it. So again, this is sort of normal, and then you kind of fall off the curve, and it's a pretty rapid decline from there. So this is your danger zone. So this is where we are with Matthew right now, in high risk of anaerobic metabolism. And so again, this looks scary, back to science, but essentially what this is saying is in aerobic metabolism, which is our normal, we use glucose, we use oxygen, and we have really high energy yield with that process. Using glucose and oxygen, we can just make tons of energy, and what's left over is some CO2, which we breathe off, and water. No big deal, everyone's happy. When anaerobic metabolism kicks in, when you're sort of falling off the curve and your body doesn't have enough oxygen, you start to use all your glucose. Well, your energy yield from that is pretty poor. So even though your body is working hard and using all the glucose and doing what it needs to do, you're really not getting all that much energy out of it. And the product of that is lactic acid. So that's why on one of the previous slides I said one of the things we look at is lactate. We can actually check the lactate levels in the blood. Lactate is that sort of burning you have after you work out really hard and then a couple days later. And that's an acid. And so when it builds up in your body, it can actually make your blood more acidic than is normal. And that's not good, because your heart doesn't like to be super acidic. And a lot of the drugs that we use don't love it when your body is super acidic. And so this is not where we want to be, but often where we are in kids that are in septic shock. So oxygen delivery, as we talked about, which is sort of everything that I do, try to optimize oxygen delivery to the body, is a combination of cardiac output. So we've already talked about that. That's how much your blood or how much your heart is squeezing out. It's your heart rate, it's how much your heart is contracting, and then how much oxygen is actually in your how much oxygen is actually in that blood when you get it out of your heart. So everything I do is really trying to optimize that. So heart rate and stroke volume, that's both what's coming back to your heart, how fast your heart is squeezing, and then what's your heart is actually pumping against. And then oxygen content is this really complicated equation, but it's essentially your hemoglobin, which are your little red blood cells. Those are your train cars that carry your oxygen. So you want that to be optimized. You want lots of train cars. And then your SpO2 is your oxygen saturation. And so you want those little red blood cells to be full of oxygen so that when they're traveling through your body, they can unload whatever they need. Again, really complicated equation. This is essentially what I showed on the previous slide, but in the actual equation format. But again, everything I'm trying to optimize. So cardiac output, sometimes I'm giving that volume. I'm giving sometimes medications to help the heart contract better. And then I don't want the heart pumping against a high blood pressure because then it just can't get out as easily. Blood is really dumb. It just goes where it's easiest to go. So if it's not easy to get to the body, it's not going to the body. So I'm trying to optimize all of that. Give blood transfusion if the kid's anemic. Optimize your oxygen saturation. So put them on some oxygen so that they can get more that way. And again, I just want to make sure their organs are perfused. So all of these things affect how much your body is using. Like I said, if you're running a marathon, you're using a bunch of extra oxygen. If you have a fever or if your temperature is really low, your metabolic rate is going to be higher. You're going to need more oxygen. Conversely, if I sedate and paralyze you, you don't need as much. So sometimes that's what I'm doing. Sometimes I'm putting in a breathing tube and sedating and paralyzing you because I want you to stop working. I want Matthew to stop working. Let me take over. Just fight the infection. Let's do the vital things, and we can fix everything else later. Drugs and toxins can affect your metabolic rate. Big catecholamine surge or adrenaline surge can affect that. And then local tissue changes as well. So if you have bad trauma or bad burns, that can increase things, infection or sepsis, and then seizures. So again, in shock, I'm trying to minimize all of these things. Make the patient normal, stop working, just fight the infection. All right, so how's Matthew doing? So we've given him a ton of fluid, and we decided to intubate him. So we decided to put that breathing tube in and get him to stop working, decreases demand, so that we can optimize his oxygen delivery. His blood pressure is better, kind of, but we said 70 plus 2 times our age, right? So 82 is actually his low end, so he's maybe still a little bit hypotensive. His heart rate is still high, but unfortunately, all of our signs are not much better. We still have really long cap refill. Her extremities are really cold, so now I'm going to start inotropes, so those vasoactive agents, so that I can augment the things pharmacologically that I haven't been able to do with just fluids. These are some of the drugs we may use for that. Again, varies in kids versus adults, which ones we use. It varies based on cold shock or warm shock, which ones we may use. And then we're always monitoring progress. I've kind of mentioned this throughout, but we're looking at that cap refill, we're watching the heart rate, we're frequently monitoring blood pressures, and then we're looking at those lactates, we're looking at blood gases, what is their acid-base balance, and all of this can help us to monitor how we're doing. We've talked about this as well a little bit, but monitoring signs of end-organ perfusion. So when you're really tachycardic, that means your heart's working really hard. When your urine output's bad, that means your kidneys maybe aren't getting enough oxygen. When you are lethargic and not very responsive to pain, that means your brain is probably not getting much. And then when you have poor capillary refill, that can be a sign that you're not getting enough oxygen to your skin, which is sort of the largest organ in our body. So all of these things I'm looking for to treat this. And then if all else fails, ECMO. So what is ECMO? For those of you that don't know, it stands for extracorporeal membrane oxygenation. It is essentially a heart and lung bypass machine. So we hear a lot about dialysis, which is a kidney bypass machine. This is a heart and lung bypass. But basically, I take a huge cannula, stick it in the neck. I don't do it, the surgeon does it. But it pulls oxygen out of the body that's deoxygenated blood, runs it through a machine, oxygenates it, and then puts it back in the body. And so when all else fails and I can't do enough to support this child, I act as the heart and lungs for them, for their body, until they get better. Now, ECMO in kids with septic shock reduced mortality in neonates to 20%. However, in pediatric septic shock that's refractory to all of our management, the survival is actually only 50% on ECMO. So it's not great, and this is still the data today. Part of that is because we can do everything to optimize how much oxygen that we're delivering to the patient. But sometimes the body, no matter how much you're delivering, the body can't use it. So you're pumping it out, giving it everything it needs, but the body is so sick and so inflamed that the body can't pull that oxygen out of the blood to use it. And that's a really scary place to be, because it doesn't matter what I do, it doesn't matter how much I support them, it doesn't matter how much oxygen I give them, they can't use it. And at that point, we're literally just praying that the body starts working again, because there's just really nothing that we can do. And that is most likely the case of that second guy that talked in the opening video when he said his organs were shutting down one after another, his toes were gangrenous. I mean, things were really shutting down because he was getting enough oxygen, but his body just was so sick and inflamed that it couldn't use it. That is not an irreversible state. He lived, and many kids do, but there isn't a lot that we can do once that sets in, not even ECMO. And that's why the mortality rate is really about 50%. So good news, happy note. So Matthew was admitted to the PICU, we intubated, we started him on pressors, and then about 24 hours later, he was extubated, and he was off all of his vasoactive agents within 48 hours. And it really does oftentimes turn around this quickly. You can get them over that hump and support their body through the worst of it. You may have some things to pick up on the back end. Their kidneys may not be very happy because they took a little bit of a hit with low oxygen for a period of time, but that stuff can just resolve over time. And the wonderful thing about kids, and one of the reasons I love working with kids so much, is that kids are they're sort of baseline a lot healthier than us as adults, and so they tend to do really well. They tend to get better, especially when you have a normal healthy kid who gets sick as stink, and then we get to make them better, and that's sort of the fun part about what I do. So he completed 14 days of antibiotics. He's actually in remission from his leukemia, and he's doing well at home. So what do I really need to know from all of this? So anyone, I think, physician or not, early recognition of sepsis or septic shock is really important, whether that's in your own children or somebody that you know. Knowing sort of the subtle signs to look for that sort of pique your suspicion, and getting quick help can really save lives. We act quickly, ABCs first, and then we're really aggressive with fluid and antibiotics because we know that saves lives, and then we're always monitoring very closely along the way. So I hope that was helpful. I haven't actually been to one of these in the past, so I didn't know how medical versus non-medical to be. I have to thank Kyle Rader, who's one of my mentors, for a lot of these slides. This was a presentation that we've actually given to nurses and stuff in the past, so I modified it a little bit and took out some of the things I thought were less relevant. But hopefully it was helpful, and if there are any questions, I will take them. Yes.
Do we need to use the microphone?
Okay. So I'm interested in what is it about the infection that pushes your body into shock, and then can we predict, like if I've got pneumonia or something, like can we predict who's kind of at risk for going into shock?
We really can't. I mean, we do know we know like if you have a comorbidity, then you're more at risk. You know, if you have pneumonia, but you have sort of underlying chronic lung disease, or you have pneumonia, but you just got chemotherapy or something that crashed your immune system, you're definitely more at risk. But it's really sort of the body's sort of inability to compensate, to adequately treat whatever is happening. And so we don't really know why I might get sepsis and the next person with the same blood infection may not. And so no, we can't sort of predict who may and who may not, but the underlying mechanism is really I mean, shock is a good word because that's what your body is sort of in this shock state, and it can't respond the way that it normally does. Normally, your body is going to have this big surge in white blood cells. They're going to go to the infection. They're going to fight it. Your body has this ability to compensate. And sometimes there's certainly, I think, certain bacteria that are more likely to give you sepsis versus others, but it's not in sort of a normal enough fashion to really be able to predict it. It's kind of a scary process, for sure. Yeah.
So when I think of shock, I think of like a gunshot, or somebody's drowning and their body's like spasming or something like that. So this shock is kind of like a slow creeping kind of shock that happens with chronic disease. Is that?
Not really. So the chronic disease can sort of make you more at risk, but the shock is actually from a pretty acute, sudden thing. So your body gets this infection, and for some reason, this time you got the infection, and your body just has this similar reaction to when you had a gunshot or a drowning or something. It's a pretty acute response. And again, you're right to sort of think about shock in that way, because shock in itself is just inadequate oxygen delivery to meet demand. And so lots of things can make your body have this shock state, but a severe infection is one of them. But it is usually sort of an acute infectious process rather than a smoldering one.
Does it go quickly? Is it something that happens fast? Like, what's the timeline look like?
Usually, you can within 24 to 48 hours be septic and sort of sick as stink. And then if you can get all of the treatments on board, you actually get better pretty quickly too. Again, some of it depends on what bacteria it is. MRSA, for example, is really aggressive. And if, for example, you can get the flu can make you more susceptible to staph, MRSA. And if you get that, then that tends to you get sick quick, like within 24 hours. You're looking pretty rough. And then again, that sort of goes back to once that happens, sort of every delay in treatment can be increased mortality. Yeah.
We have evaluations up here, and in the back, so please everybody fill out an evaluation for you.
Yeah, definitely please do. And if there are things that you're looking forward to in the future, both in terms of topics of discussion or the way that you would like these talks to go, that would also be helpful too. There are several fellows that have already stepped up and are excited to give lectures in the future. So there's some on heart failure. There's a nephrologist who's like, I'm open to talk about whatever. Same thing with one of our rheumatology fellows. And so if you have any kidney topics or rheumatologic topics that you think would be great to hear about, please let us know, and we'll sort of try to guide these appropriately so that they're helpful for you. Okay?
Thank you so much.
Yeah, absolutely. Thank you all.